So good evening, everybody. Thank you for joining us. My name is not Melbourne ACE. My name is Anthea Cochrane. I'm the Academic Director for Melbourne ACE, and I really welcome you to this evening's extension event. I would like to acknowledge that I'm zooming in from the lands of the Wurundjeri people and pay my respects to their elders past and present. This is about our fourth extension workshop, and I'm delighted to welcome Woodhart and Tara Case as our presenters this evening. They're both from the Going Rural Health team, and they'll tell us a little bit more about themselves, but they're going to talk to us tonight about rural health clinical education, innovative approaches for engagement and impact. And I just want to give you a little bit of background for Melbourne ACE. We've had some work being done on something called the Jem Scott Fellowship by two colleagues from the University of Melbourne, Carolyn Johnson and Wani Yu. And this is just a slide of some of the findings that they've discovered from a big survey that a number of you might have been involved with. And as we're thinking about things that you might be wanting to be engaged in, we're using this as a bit of a guide, but please feel free to reach out to our email on the Melbourne Academy of Clinical Educators website that you can find at the University of Melbourne to give us any suggestions of what you might like. Just letting you know we are recording the event this evening. We will top and tail it, so it'll be Lauren and Tara's presentation, not the Q&A probably, that we will then make available to others who weren't able to come to our event. And I would just like to thank Lauren and Tara for also doing this event on Monday evening face-to-face, which was wonderful. And the final thing just to let people know is that the Clinical Supervisor online training course that you might have seen on the Melbourne ACE website, and some of you might know in a previous iteration, has now been relaunched officially on Monday for people to access. And part of Melbourne ACE's mantra will be to try and provide some opportunities for some University of Melbourne and other clinical supervisors this opportunity to do this course free of charge. It's an asynchronous, about 6-hour course, but that will take some time to roll out, so don't expect it straight away. However, we are progressing on that. So at this point, I would like to now hand over to Lauren and Tara for this evening's presentation. Thanks very much.
Great, thanks Anthea, and thank you for everyone who's joined us tonight. I'd like to start by just extending on Anthea's acknowledgement of country by also noting Bangarang country, which is around the Wangaratta region, where the office is located that I work out of, and also Wathaurong country around Ballarat, where Lauren's based. Lauren and I presented this in person on Monday evening in Melbourne, like Anthea mentioned. So we've got a bit of a reduced time slot compared to that. So if it feels like we're rushing through some slides, apologies, but we do just want to really make sure there's that time at the end for some comments and questions. So yeah, hopefully it doesn't seem like we're speeding through too much. So in today's presentation, we're really going to be looking at providing some background to the rural health landscape currently, look at the rural health student placement context, what the strengths and opportunities are, and then I'll hand over to Lauren for the second half of the presentation, where she'll be presenting some of our student placement models, some of the tools we use to support those models. And if there's time, we might be able to show some brief case studies. We'll see how we're going. So in preparing for today, Lauren and I were thinking about who the audience would be, both at the in-person and online event. If people are happy to, it'd be great if they could pop in the chat where they're joining from. It'd be good to just get a sense if people are mostly joining from rural areas or metro or a mixture, just to get an idea of, who I guess perceives that rural health is relevant to them. And I think that's something that we're hoping to really demonstrate in today's presentation, that regardless of if you are working and living rurally, it's really everyone's business, rural health. Even if you're not living in a rural area, you're likely to have family or friends that do. Perhaps you visit rural areas, holiday there and need to access rural health services during that time. But even if you're working clinically in a metropolitan area, you really need to still have an understanding of the rural health services that you interface with so that you can effectively discharge, plan, and just to ensure that continuum of care. So we're part of the Going Rural Health team. Some of you who have joined today hopefully will know a bit about us or may have worked with us or collaborated with us. Some of you may not. So just very briefly, we're a multidisciplinary team. I think currently we have physio, speech, OT, medical science, nursing and administration staff on the team. Hope I haven't missed anyone there. And we sit across 3 sites, Ballarat, Shepparton and Wangaratta. And we're part of the broader University Department of Rural Health, of which there's 19 across Australia. And those University Departments of Rural Health are funded federally to support workforce in the rural areas through a number of different strategies. But the team that we work in the Going Rural Health team, you'll see there we've highlighted some of the services and supports that we offer to support rural health and more specifically to support nursing and allied health students to undertake rural placements across our footprint. And it's just worth noting that because of the way we're funded, we not only support students from the University of Melbourne, but students from other universities also. And you can see there, just in summary, we provide a range of supports. You can go to our website to learn more about those, but they're student accommodation, financial support, cultural training, a range of education programs, and some wellbeing supports. And we also target our support not only at students, but at the health staff that support them in our footprint. Thanks, Lauren. And this slide here, it might be a bit difficult to make out in the blue regions, the names of those areas, but that gives you an idea of where our footprint sits across Victoria, and you can see that it's quite spread out. And we work closely with other UDRHs who service different areas across Australia, but it just gives you a sense of where we're located. Just for simplicity today, throughout the presentation, we will use the term rural to encompass areas that are classified as either rural, regional or remote. Having said that, much of what we talk about today is really relevant to rural and regional. There are some similarities to remote health, but it is a unique context in and of itself. So when we talk about rural health, what does that look like currently? We know that people living in rural, regional and remote areas of Australia make up around 30% of the population. While that's not a huge percentage, rural areas of Australia are really the backbone of our economy. We provide over 70% of our export income, over 50% of tourism income, and provide over 90% of Australian food supply. So even if you're not living rurally, you are relying on rural Australia. So there are lots of advantages to rural living, and I think anyone who lives in rural areas that's with it online tonight would probably attest to those. We really enjoy rich cultural diversity, lots of beautiful natural environments. There's really strong community connections and high levels of social capital, or that social glue that connects people. And we enjoy really distinct lifestyle and wellbeing benefits. But there are unique challenges, and one of the obvious ones is geographic isolation. We have increased exposure to climate impacts and natural disasters, things like bushfires and floods. And there are infrastructure barriers, again, connected to access and geography. But, one that students will often notice very quickly is connectivity is often a real challenge as well. So what's the impact of those challenges on the health of rural Australians? And what we know is that we have reduced health outcomes in comparison to people living in metropolitan areas. And that includes higher rates of hospitalisation, injury and death, higher rates of chronic disease, more people living with a disability, reduced life expectancy and poorer mental health outcomes in comparison to people living in metropolitan areas. And that's underpinned by a number of factors, but social determinants of health impacts those outcomes. So that's those non-medical factors that impact health outcomes. So we have reduced rates of income, higher levels of unemployment, lower rates of education attainment, and distinct housing pressures in rural areas. We also have unique barriers to accessing services. There's just fewer services available as well. So those services that are available geographically and financially, there are implications to being able to access those. And we know that there's workforce challenges in health across Australia, but there is a significant maldistribution of the workforce that favours urban areas. So recruitment and retention is a big issue for us. But we also know that the workforce that does exist in rural areas can face limitations because of that in terms of resources, supports, supervision, and that can lead to professional isolation and increased rates of burnout. And just because of the dominant industries and the road systems, we're also at increased exposure to occupational risks in those dominant industries. So if we are going to kind of impact those disadvantages or inequities, we need to have a really comprehensive multi-level approach. And a really critical piece of that puzzle is providing high quality student placements. So we know from the literature that student placements are a really critical way to build the rural workforce and a really vital way to make a sustainable impact in that. We'll talk a little bit more in a couple of slides. We'll look at the student benefits to rural placements, but obviously beyond student benefits, there is the contribution to workforce development. They also promote intention to practice. There was an interesting study done by our research colleagues in the UDRH who looked at intention to practice, and they found that undertaking a rural placement, not only, we often focus on students who are rural origin and we know that they have higher intentions of rural practice, but students from metropolitan areas were 6 times more likely to report positive change in intention to practice following a rural placement than those from rural origin. So I guess that just really highlights that need to target rural placement education, not only at rural origin students, but more broadly. But also just student placements in rural areas just raise the profile of rural health. They talk about rural health, they understand rural health, and they really make a valuable contribution on the ground. Sometimes they're providing services that otherwise wouldn't exist at all, or at least maybe contributing to capacity of those services. And they're also living and contributing economically to communities in rural areas. So they're eating at the restaurants, their friends and families are visiting them. They might be travelling to other small towns in the area to visit places. So they really make a valuable contribution beyond their own personal benefits of placements. In this next video, we're just going to show a really short snapshot of the work that Going Rural Health does. And also it will highlight some sort of first-hand student experiences. Thanks, Lauren.
There is a shortage of nursing and allied health practitioners in rural and regional areas, but we know that these services are crucial to meet local health needs in local communities. Rural and regional communities face difficulties in accessing appropriate healthcare and in recruiting allied health and nursing professionals into the regions. And that's why students are the future of rural healthcare.
The Going Rural Health program has been designed to help students going on a rural placement, and we know these needs are because the cost of living expenses are so high. So we're trying to address those by offering support services to students like subsidised accommodation throughout regional and rural Victoria. It really allows the student to focus on their rural placement and have the most positive experience they can.
So this is my first rural placement. I would say some of the benefits I've experienced so far is the autonomy in learning. I guess in a metro hospital you are constantly under that supervision, which one can be quite daunting and I guess affect your performance sometimes. So it's really nice to have that independence and see how you might function as a clinician. Working with the patients has been really lovely. It's a really lovely community out here and everyone knows everyone. It's just a really lovely environment and it's really great because you get to spend so much time with patients due to the slower pace. You get to see them make these advances and improve, and you get to see really tangible outcomes, which I guess you don't really get to see in the fast-paced hospital where you go from one patient to the next and there's a lot of turnover. So it's really nice to see your, I guess, like studying and hard work making a difference.
I chose to do a rural placement because I feel like I wanted to challenge myself, try something new, and feel like I can give back to a community that may not have access to care. When I was in Horsham, over the weekend I went to the Grampians both days, which was really fun. I really got to see a part of Victoria that I've never been to. I might not have gone to if I hadn't had rural placement there.
All our students go rurally because rural placement is where they learn the most, and when we ask them at the end of the year, it's actually the most valued placement that they've done in the whole year. There's not as much healthcare usually rurally, so the students have to step up and do more, and that just really places them in a good spot to be ready to graduate. So we highly value all our students going rurally.
I love students. Watching them grow is everything to me. So often the allied health students come in having no experience in rural health at all, having no idea what they're getting into. And by the end of it, the smiles on their faces and the experiences that they've been able to have is just so rewarding.
Thanks, Lauren. So you heard from some of the students there what they perceive to be some of the benefits from rural placements. And we've been lucky across the last 10 years with the Going Rural Health program to have collected a whole lot of data from student surveys that have undertaken rural placements and been able to pull out some of those themes and understand what they feel is beneficial from their rural placement experience. And in summary, they talk about things like exposure to breadth of practice. They recognise that they see a really broad range of clinical presentations that they feel they may not have had the opportunity to do on a more specialised metro placement. They really value the rich interprofessional environments in rural areas. They recognise that it was a time of personal growth for them, and they really talk about enjoying the independence and the autonomy, and that they really felt that helped develop career readiness skills. They really liked the small communities and being made to feel really welcome. They felt they were making a really meaningful contribution to their work and were able to see the outcomes of that. And they talk more broadly just about the clinical environments being very positive, supportive and collaborative. Those themes are also echoed in other research that the other UDRH departments have done looking at their student placement experiences as well. So we know and we hear from the students from those surveys that even though some students are apprehensive about coming, that overwhelmingly they report really valuable positive experiences from rural placements. But there are challenges, and one of the ones that we hear a lot about, particularly because of the current cost of living, is the financial strain of placements. And obviously the supports that our program offers are really set up to try and minimise that, but it is a reality. If students are coming rurally, they might have to not earn their normal work through their jobs. Their jobs may even be in jeopardy if they're having long times away from them. They might be paying rent in metro areas, but also paying accommodation costs up here. There may be costs associated with transport and travel to country areas. There's also an increased risk of natural disasters, so we have to be really mindful of that in our placement planning. In our areas, we've had bushfires, floods, things like this that have really jeopardised student placements, but also meant we've really needed to be vigilant about looking at risk and safety when students are on placement. There's obviously geographical barriers, and a lot of students might not have a car at all, and then transport might be an issue to access their placement in a rural area. Or even if they do have a car, you know, we need to consider if they used to travelling long distances or on country roads and dirt roads and kangaroos and all the things that they may not have experienced before. Obviously, there's accommodation pressures. Often we have student accommodation in areas, but if not, we try and support students to access that, but that is a challenge. And then there's the wellbeing impact of coming rurally. For some students, that they really see it as a adventure and an opportunity, but for some students, they can be apprehensive about coming. They might be away from their normal supports. For some students, it might be the first time that they've actually been away from home. So we really need to plan and embed wellbeing supports and just be aware of that. And then there's the infrastructure pressures, particularly they might still have study that they're trying to do. So if the Wi-Fi is not good or they don't have access to services or supports themselves, you know, some students might feel the impacts of not being able to access health services whilst they're on placement. And then finally, the limitations they might face in terms of professional supports and resources, and that could be supervision, PD, just some of the existing resource limitations in rural areas. So even though we know that those challenges exist, we really need to look at still trying to take the opportunities and look at the strengths of rural practice and really leverage those to design high quality student placements that contribute to workforce development in rural areas. And this diagram here shows what we see as some really critical considerations or components of rural health education. So one of the first ones is planning, and that pre-placement phase is really critical in rural education. As soon as we get student allocation, we'll send via email some information to students about where they're coming so they can start to consider accommodation. And then we'll continue to communicate with them, and usually we try and then offer them an online catch-up in the week or two prior to placement where we can really informally just start to understand what their expectations are. Do they have any questions or concerns? Do they have accommodation sorted? And then that planning really sets up the success of the placement. Innovation, adaptability and resourcefulness are also really key to rural placements. We know traditional models don't always fit well in rural areas, so we need to design placements that are really responsive to rural needs, are very usually complex in their design, but also very resourceful and creative. Both clinicians and students need to be able to think on their feet and think outside of the box as well. Our placements need to be culturally informed. A number of our placements are in First Nations communities, and we embed cultural training across our sites for students in the particular region that their placements is being held. Community connection is really important, and you know, we really try and work with community to have a shared understanding of placement and the health needs before the students even arrive. All of our placements have an interprofessional focus, and that really just reflects how the placements are, or the areas or the context that they're in rural areas. And you'll see from Lauren's presentation later how that's interwoven through the placement design. A really key thing we talk about a lot is sustainability. We really try to avoid with student placements coming in and providing a service perhaps that might not be there at all, or expands a service, but then at the end of the placement, when it finishes in, for example, 5 weeks, the students leave and there's no sustainability of that. So it might be that there's no referral pathways if the students have done assessments or screening. So we really need to, I guess, be mindful of ethically how can we set these placements up to be capacity building in their focus and really embedded and have sustainable outcomes. And finally, relationships, which I think is probably can't be overstated. And I think anyone who works rurally knows the significance of relationship building. It takes time, and it takes a lot of effort by everyone's part, but it really is central to placement planning. And you'll see when Lauren talks about the models that we use, they're very complex. There's a lot of stakeholders and a lot of moving parts. Things change and evolve. And I heard someone speaking recently who was an experienced placement provider, and they said, if the relationships are strong, everything is solvable. And I think in my experience, that's really true. Things will change and there'll be fires that need to put out along the way. And I think if that strength of relationships is there and trust has been built, anything's possible. Thanks, Lauren. We can't just expect rural health to generate good quality rural placements. There are lots of people involved to make that happen. It's a shared responsibility and everyone has a role. So universities are really key in advocating for rural placement opportunities, for valuing rural health, for providing education and curriculum in rural health, and looking for opportunities to partner with rural health. The clinical educators themselves are obviously critical in providing that workforce development, mentoring and education for students. And the students, we really need the students to be open to rural placements, to be curious, to come to rural placement opportunities with the enthusiasm, engagement and willingness to build capacity in rural areas. All health professionals and health services and community groups in rural areas also have a role to play. They are the ones that, even if they're not providing direct clinical supervision, they're modelling into professional practice, or they're advocating for rural health, or they're just helping the students develop and strengthen their understanding of rural practice. Rural communities are also really important, and there's some research that talks about this from Kath Cosgrove around the role that rural communities play in recruitment and retention of the health workforce, helping people to feel welcome into communities and then integrating health workers. And that idea extends to students, in that if we support students even in those early stages of their career, they're more likely to have a positive experience and look at coming back to community regions. And finally, governments obviously play a really important role in terms of finance and policy to support rural health, and a really important part of that being student placements. Just before I hand over to Lauren to talk more about our placement models, I just wanted to really briefly touch on our education approach across the Going Rural Health team. So we have a really comprehensive education program, and the audience of that is not only students, but also health professionals across our region, as we see them as critical to the support provided to students on placements, as well as community stakeholders. So we might work and provide education to teachers at a school that we have students interacting with, or a neighbourhood house that we have students involved in a program there. So we'll provide those staff or volunteers with information about what quality student placements look like and how we can support students whilst they're on placement. Our education, wherever possible, has an interprofessional focus to reflect the rural workforce. And it also has multiple delivery modes. So we do online, in-person, small group, large group. Wherever possible, it's community-based and needs-driven. And we're really responsive at looking at what are the needs across health professions and students each year. And we try and collaborate to deliver that education. We know resources are limited, so collaboration is a really important part of that. And we try and focus on rural context. So even if we have, say, someone coming who's visiting from a metropolitan area to provide education, we try to talk to them about what this might look like in a rural context, or what the considerations are for a rural context, so that we know that education is tailored to our audience. And just finally, in practice, what that might look like, and Lauren will talk a little bit more about some of this education, but we have a weekly interprofessional online tutorial program that's offered to our students across our footprint, and is facilitated by the Going Rural Health staff. They have a career readiness skills tutorial, a peer-assisted learning tutorial, and an ownership of learning. And that's really a chance for the students to come together, talk about clinical learning in each of those areas, perhaps do a case study, and really just share experiences and learn from each other's placement experiences. We partner with other organisations and groups to provide specialised education, and some examples of this are we've partnered with Search, who are the Centre for Excellence in Rural Sexual Health, to provide sexual health promotion education to interprofessional audiences, both students and health professionals across our region. And also we partnered last year with the Voluntary Assisted Dying Navigating Service from the Hume region, and they delivered some VAD training to health professionals and students as well. So that's also a really important part of our education delivery. Our cultural training, like I said, is delivered across our footprint for both students and health professionals. And then we have a multi-tiered supervision training that has like a foundational level workshop, an intermediate level, and also what's called an innovative approaches to supervision session, which really is about talking about some of the tools and models that Lauren is about to present, and provides an opportunity to invite services or organisations who might say to us, I don't think student placements can work for us. We have a part-time workforce, or we only have one discipline on site, or we just don't have the capacity. That session's designed to sit with them and perhaps think of some of those tools that are a bit outside the box, and also mentor them to think about how might this look, or what could be a creative way to still be able to support students in your service. And finally, we have an interprofessional supervisor forum twice a year online that brings together all our Going Rural Health supervisors that are able to attend, and they're across the disciplines, and it's a really valuable way to provide some professional development that they've highlighted they're interested in. One of our supervisors will usually present a brief case study on their supervisor role, and then it's just really the supervisors having the chance to talk to each other and learn from each other. A lot of our clinical educators either don't work side by side with other educators, or perhaps they don't even work with someone else from their discipline. So they really value that opportunity to talk about their supervision, troubleshoot what's going on, and just learn from each other's experiences. So hopefully that gives just a snapshot of the education work we do and provides some context for our placements. And now I'll hand over to Lauren, who will outline those placement models and the theory in more detail. Thanks, Lauren.
Thanks very much, Tara. I'll just check the time, and we're doing quite well for time, which is good. I would encourage people, if you do have some questions based on what Tara has said, just to feel free to put them in the chat if you would like to, and we'll loop back to those at the end. I've also just realised too, it might be good for Tara and I just to introduce ourselves just a wee bit more, just so that you get to know us, I suppose. So
sorry, Lauren, that was my fault.
No, that's fine. No, we can do it now. So I'm Lauren. I'm a physiotherapist by clinical background, and I was born and raised in northwest Victoria in a little country town called Rainbow. And my clinical sort of journey, I suppose, has taken me to rural and regional locations in New South Wales and Victoria. So I'm now based in Ballarat, which I think is a really nice little segue to lots of different rural areas as well as into metro. But I really do have a passion for rural health based on my background, and also I've had opportunity to work in different interprofessional teams as well. So I've learned a lot about other disciplines. So I am really enjoying my current role in interprofessional rural education with Going Rural Health, which I've been in for about 3 years. And prior to that, I worked as a physiotherapy supervisor on a casual basis for Going Rural Health, which was really great because I learned a lot from the team in those years as well about service learning and different clinical tools for rural clinical education. I'll just hand back to Tara briefly.
Thanks, Lauren. Sorry, I omitted the part of introducing us. I think I was so keen to get our skates on and not go over time. Yeah, my background's occupational therapy. I've worked with the Going Rural Health team for around 5 years in different capacities. So provided clinical OT education, also placement coordination, and more recently coordinating the education program across Going Rural Health. I also have lived and worked rurally most of my life up on the border of Albury and Wodonga, and I am also currently doing a PhD program through Melbourne University that brings together, I guess, my interests in rural health and clinical education, and also OT specialisation in mental health, and that is a trial across Northeast Victoria in kindergartens looking at a preventative mental health program that, I think, really nicely marries those areas of interest for me professionally. Thank you.
Thanks, Tara. That's really great. So just a quick recap, Tara has provided some context to rural health and what the Going Rural Health team does across our 2 footprints in rural Victoria. And in this next section, I'll talk more about our clinical placements, and I'll be focusing on our service learning model, as well as some of the tools that we use for clinical education in the rural context. We support students undertaking a mix of different types of placements. So students do undertake traditional placement models across our footprints, as well as the service learning model, which I'll talk about. And just for some context about the size of the program, last year in 2024, 950 students got some support in one way or another from Going Rural Health. And they completed over 1,100 clinical placements across our footprints with an average placement length of at least around 5 weeks, 5.5 placement weeks. And of those 1,100 clinical placements, 150 used the service learning model, and these took place across 30 different service learning sites. So we want to highlight service learning today, even though it's a small component of the overall number of students and placements that we support. It does showcase the innovation in our placement approaches, and from our experience, we see that service learning has potential for large impact for both the rural communities and for the students. So service learning initially evolved in university programs in North America, and it's widely used internationally throughout a range of disciplines, so beyond health, such as in education and in engineering. Going Rural Health was an early adopter of service learning in Australia from 2015, so we've been running service learning for about 10 years now. And whilst there's no consensus on the definition of service learning in Australia, Going Rural Health has employed this definition from Cypher and Connors. So I'll let you have a little quick look through there, but it does highlight meaningful community service as a main component, along with teaching civic responsibility, strengthening communities. It's a very structured program with a lot of preparation to it. And it gives students a community context to their education, allowing them to connect their academic coursework to their roles as citizens within the community. So service learning is an innovative approach or type of work integrated learning or clinical placement, and it's more commonly used in resource-constrained settings, so such as rural and remote Australia, where there are workforce recruitment and retention challenges. Service learning aims to provide reciprocal benefits to all stakeholders. So it's really about balancing student learning with providing or addressing some of the healthcare needs of the community where the placement is taking place. It also aims to benefit end users. So by that I mean clients or patients. It also aims to benefit staff within the host sites and the existing allied health workforce, so the clinical educators and the supervisors. Through development of meaningful partnerships with host sites, service learning is purposefully co-designed to respond to specific identified healthcare needs. And in response, students are exposed to real-world and quite diverse practice settings, those non-traditional placement settings. Through using collaborative supervision models, students experience interprofessional learning and practice. So they have the opportunity to work with people from different disciplines, and they have the opportunity to work more autonomously as well, which promotes their career readiness and a deeper knowledge of their civic roles. Students are supported to provide direct service provision where there are limited services, and they can also undertake projects that really help to build capacity. So service learning, you may have heard it be referred to as student-led services or student-assisted programs. And just the bottom point there, I'll draw your attention to, service learning is used throughout Australia by the other university departments of rural health. So the paper referenced at the bottom is by Monica Moran and others, and this work has come out of the AREN Service Learning Network. So that's the Australian Rural Health Education Network that we're connected into. And the paper was a national survey of Australian rural and remote service learning placement implementation that's been published in BMC Medical Education, and it looked at how service learning is implemented across Australia. So at the time, there were 17 UDRHs around Australia, and of those 17, there were 12 that were facilitating service learning in one way or another. And service learning was being routinely embedded within schools, aged care settings, home, and other community organisations as well. So with the Going Rural Health Service Learning Program maturing over time, sort of over the last decade, in 2023, our team developed a conceptual model of the approach that we use for service learning, and this was based on experiences of over 400 placements over 6 years. To put this together, we used an iterative approach where we met regularly. We integrated existing service learning concepts as well as evidence, and we used critical reflection to refine the model. And we came up with 10 key elements within our model. I'll just draw your attention over to the right of the screen there. That's the paper that we had published in 2024 in the International Journal of Work Integrated Learning, or you can access it via the QR code. If you're interested in finding out more about the model and the methodology, then I would encourage you to have a look at that paper. But key aspects really do highlight forging those really strong relationships with all of the stakeholders, which Tara talked about earlier, and also interaction between all of the elements in the model. So on the left side, there are the key stakeholders involved. On the right side are the processes involved in designing and delivering a service learning placement. So if we undertake all of those elements simultaneously, it enables us to implement placements into a really vast range of practice settings across the life course. So that can be from paediatrics right through to gerontology, within schools, within the disability sector, homelessness and hardship, mental health settings, and residential aged care settings are some of the examples. So through conceptualisation of the model and with the program maturing further, we were really ready to start formally evaluating the program across all of the past and current service learning sites. So this year we are working alongside one of our Department of Rural Health research colleagues, Robin McNeil, to undertake an evaluation. The overarching aim is really to determine the impact of the Allied Health Service Learning Program for key stakeholders. So these stakeholders include the end users or the clients or the patients that receive the additional allied health services through the student placements. But we're also evaluating further the impact for students, the impacts for the host site staff, so the people who are on site with the students coming in, and also looking at the impact on the individual clinical educators and supervisors who are involved in supporting the students. So we're aiming to complete this evaluation work by the end of this year and have some publications come out of that. I'd now like to share some of the practical tools that we use as clinical educators to successfully run our placements. And these tools enable us to implement service learning in a broad range of settings in the rural context. And a lot of these placements are in non-traditional placement settings. Whilst I will be presenting these in the context of service learning, I'll just signpost that any of these tools can be useful in any student placement context, including more traditional placement models. And if we have some clinical educators amongst us tonight, I'm sure that you'll be using some or all of these already. So the 4 key tools that we using at the moment are peer-assisted learning, collaborative supervision, capacity building projects, and reflection. So I'll go through these one by one, starting with peer-assisted learning. So we always pair our students on service learning placements, and we do find that students form their own team while they're on the placement. So they can share ideas, they can practice skills together, they provide opportunities for each other for observation and for feedback for each other. They also support each other socially as well, and in debriefing with each other. So as you've heard from Tara, Going Rural Health runs the fortnightly peer-assisted learning sessions for our service learning students who are on placement across our footprints in Victoria, giving these students the opportunity to come together via video conference and to reflect on their experiences. In terms of benefits for students and clinical educators, there are lots of them from PAL. The research shows a lot of benefits, and some of these are for students: enhanced student autonomy, enhanced feedback, self-reflection, enhanced peer support, enhanced confidence, practical and academic performance as well. And for clinical educators, there are actually time and productivity benefits to having two students. And that might sound a little counterintuitive, and it's certainly a common aspect that comes up when we're talking with clinical educators. But once the orientation period is completed and the expectations are well aligned, we find that students can really assist with taking a caseload and providing service delivery, whether that's through the caseload or through capacity building projects. And you can send students off together in their pair to work together, supporting each other, rather than a supervisor having to be with them all the time, or the student demanding that attention from the supervisor all the time. Collaborative supervision is a feature of our service learning placements. And as Tara mentioned earlier, because of workforce challenges and sometimes, we have limited discipline-specific supervision available at a site, the supervision models really do have to be innovative and flexible for placements to work well. Collaborative supervision, it's a strategy to build the capacity of work-integrated learning. So where there is a stretched workforce, it reduces the load on any one person or any one supervisor, and it can actually enable a placement to happen when otherwise it may not be able to happen. The models of collaborative supervision provide opportunities for students and staff from different disciplines to support each other and to learn from, with and about each other. So it promotes opportunities for interprofessional learning and practice. Although, as we know, the different allied health professions have their own unique services and scope of practice that they work within, we all do have shared skills and qualities. And I think this is really good to reflect on. Some of these skills that we all have include things like interpersonal communication, discharge planning, working within teams, education skills, advocacy, clinical reasoning, implementing evidence-based practice. They're all things that all the disciplines do. So there are lots of very rich learning opportunities for students to learn foundational skills from others in the interdisciplinary team. So for each site, we do have to identify the supervision needs and solutions that are unique for each site. And solutions can include Going Rural Health team members providing some discipline-specific supervision themselves. We can also, and we also do source external supervisors. So if the site can't provide a supervisor themselves, we can reach into our networks and see if we can find an external supervisor from our local area. And we also have a role in sourcing funding solutions to cover those external supervision costs. For these models of collaborative supervision to work, we do need to consider the students' level of experience and their scope of practice. So there does need to be a level of autonomy in practice with the students, because they are expected to work more autonomously in their pair. But having said that, we certainly do have some service learning placements which do run with less experienced students. Just the points down the bottom, 1, 2, and 3, they are that's the Going Rural Health model of a collaborative supervision model. So we have 3 people involved at any one site. There's a host site key contact that provides day-to-day support for students on the site. And for example, if we're having students coming into a primary school, that host site contact could be a leading teacher or a principal. The second person involved is the discipline-specific supervisor. So that's the clinician who teaches the clinical skills. And ideally, this supervisor should be local to the area and have a good understanding of the unique health needs of that local community. And they should have clinical expertise in the area of practice that the students are working in. It's also the responsibility of this discipline supervisor to complete the assessment tasks required by the home university. And then the third person involved in the model is the Going Rural Health team member. So one of our team provides interprofessional mentoring and support to the students. So as Tara mentioned earlier, our team is made up of different allied health and medical science clinicians. And these people are involved in coordinating placements, providing the pre-placement supports for students, meeting with students at the placement sites for formal mentoring and debriefing. And they also support the host site and the supervisors throughout the placement and are really involved in that operational aspect of the placement. I'll move on to the next point, which is capacity building projects. And this is a really core component of service learning. As Tara mentioned, it's all about building capacity and sustainability within the sites. So what we really do want to highlight is that we come in and alongside staff and volunteers at the host sites, and we really do need to spend time understanding their site and consulting them, because they're the valued experts of their community's needs and their service gaps. So we don't want to come in and have this effect of telling a site what to do. It's very much coming in alongside them and spending time understanding their needs. And then the students' coursework and their scope of practice is then integrated into those ideas that the site comes up with around needed service projects. It's really important at this point that we liaise with the home university during this placement design phase, because this ensures that the intended projects match well with the university curriculum requirements and with the students' learning objectives as well. But I will just stress that with the service learning philosophy, it's the identified needs of the host site that remain central to the planning. So there are some examples of projects just in dot points there. Service delivery is a big one. So that's where students can provide some needed clinical assessments and therapy sessions for clients, where those clients would otherwise have no access to that service or very limited access, or perhaps a long wait for that service. The second one is resource development. So an example of this might be, for example, in the school setting, where physio or occupational therapy students are coming in to provide some services. They might be involved in providing some movement breaks or brain breaks for the children, and that's a really embedded movement break that children are involved in across schools. And the students can then create some resource cards for the teachers, so providing some information in the form of activity cards that help the teachers to then implement those brain breaks if the students aren't there for a period of time. The third point is interdisciplinary staff capacity building. So this is a project where students can present education sessions to staff, as an example. So in an aged care setting, we might have physiotherapy students who are working with clients, older adults with Parkinson's disease. And the physio students, with their expertise on movement and gait training, they can help nursing staff with some recommendations to implement for assisting a person with Parkinson's disease to walk more independently and safely. And that's something that they can implement into their day-to-day care with that client. So you can see as students apply their coursework through these agreed service deliverables and projects, gaps in service delivery can begin to be addressed. And concurrently, students develop an understanding of their professional roles, but also their civic responsibilities within the context of the community that they are undertaking their placement in. So that leads nicely into reflection. And I'm sure all of you who work with students or even as clinicians know that regular reflection really helps with developing a number of positive aspects. So things like clinical reasoning skills, helping to link theory with practice, and creating that cycle of continuous learning that we all should aspire to. So service learning by its nature, it encourages students to become more aware of their own privilege, of human rights. So for example, the human right of equal access to healthcare, and awareness of each other's needs. And it can be potentially quite transformative for the students. It doesn't just happen on its own, though. We really have found that we need to provide some formal reflection tools and scaffolding to help with that process. So some of the tools are engagement in the formal student peer-assisted learning sessions that Tara talked about earlier, the online sessions that bring students from different disciplines together. But we also meet with students regularly on placement for mentoring, and we can implement some reflective practice into those meetings. And we also use some reflective journaling for some students in some of our placements as well. So overall, service learning is a very structured program. It is very time intensive, but once it's well set up, it can really help to build capacity, not only at the host sites, but also within the students as well. I'll hand back to Tara.
Thanks, Lauren. We'll pretty much wind it up there. We were hoping to be able to have time to provide some case studies, but we won't. But just know that we pretty much offer over 30 last year host sites hosted a range of different discipline student placements. So if anyone wants to hear about those or learn more specifically about a particular discipline or host site, please reach out to us and we're happy to share some information about that. And just the last slide before I hand back to Anthea, our service, Going Rural Health, you'll see there, our team sits beside the Aboriginal Health Team or MELCA team and also the research team as to form the University Department of Rural Health, but we also sit in the broader Department of Rural Health with the clinical school, the regional training hub and the Centre for Excellence in Rural Sexual Health. So you can see there's lots of expertise and experience in the department. And we really like to collaborate. So please reach out to us. And even if someone in our team can't help you, we will know who to give your contact detail for. And yeah, really always looking to promote and collaborate with rural health. Thanks, Anthea. We might hand back to you to take it from there.
So thanks so much, Lauren and Tara. We can possibly unshare, I think, yeah, thanks, Lauren, and that'll just make it easier to see when people have questions. And we do have up until 7:15 and hope you can stay with us just to ask questions, and you're welcome to pop questions in the chat or just raise your hand. And we do already have a question from Karen that you might be able to see, but the question is, how can we arrange for students on placement to access the weekly tutorial program that was described?
Lauren, you feel free. I was going to say, probably Karen, the best thing would be to find out where you're based, and we can have a conversation about that. We can have someone have a chat to you about that. Just check if it matches your student needs and go from there. So more than happy to give you some information about that.
Tara, are they usually interprofessional when they can be, so that you might have different types of students at a location, but they're located a bit remotely, you know, even in the same town perhaps, but at different service sites, so you try and get them together? Is that the idea?
Yeah, and it can be right across our footprint. So they could, someone could be in Wodonga, for example, someone in Ballarat, someone in Corryong. It just depends who's on placement at that time and what disciplines there are. But yeah, that being interprofessional is a really key component of them.
Yeah. And is there a specific day or time per week, or does it just depend on which students are around and which staff are around?
So the 2 or 3 staff members who usually are the key facilitators for them, and they're offered on a fortnightly basis that scrolls through those 3 different tutorials that we mentioned. And they follow a fairly structured format, but they're obviously facilitate them to meet the needs of that particular cohort on the day. Lauren, do you want to add anything to that?
I think that's covered it pretty well. I mean, at the moment, when we're aware of students in our footprint, so generally the service learning placements, we work very closely with those placements. So we automatically will pop those students into the calendar for those tutorials and share the Zoom links with them. So for other students though, that might be something, I think it would be best to reach out to Tara in the team or someone else in our team to see what we can arrange.
Thank you. Does anybody have questions that they'd like to raise their hand for? While we're getting some questions, I was just going to ask a question. I know one of the big challenges, so I'm an optometrist for those that don't know me online, and one of the big challenges is to encourage some of our supervisors to take 2 students at a time because they feel overwhelmed even taking one. So the idea of taking 2 can be hard, but you've already commented on how much strength there is in 2 students coming together in your service learning model. Can you just comment on that? How do you get people over the line?
One thing we do find really helpful is providing some more formal training on peer assisted learning principles and practical tips. And we have actually been able to run some peer assisted learning workshops at some host sites and some health services. So there are some providers out there, and I think we have a module as well. So I think that's one big key thing, is just to really spend some time delving into what it is and some really practical applications of it. What does it look like? How do you set up your timetable? What things can you send the students off to do in their pair? How can you make sure that's safe for the students and the clients by choosing low risk patients and things like that. So I think it's worth spending time in some education for staff, and that might bring them around.
Yep.
Yeah.
Yeah, thank you. Have we got anybody that would like to raise their hand or ask a question? So while we're waiting, I'm going to ask another one, and I'm going to ask this time about the difficulty of students being somewhere when there is no supervisor. And I need to admit that I've already seen this in real world. So Lauren was able to assist when we had some students at a site at Skipton Beaufort and we couldn't have a supervisor there all the time. But can you describe how you make the supervisor, which was me, comfortable that I'm not going to be there, but the students will be okay?
Yeah, and I think it's having those conversations pre-placement about the different activities and learning activities that are available at that site. So in that instance, we had overlap with other disciplines of students. We had occupational therapy and we had physiotherapy, we had social work, I think, as well. So we could talk about, well, the physiotherapy students will run this exercise group with the older adults in aged care. Would the optometry students like to come along? Would you like that to be an experience your students could have? And you said, yep, that would be a great opportunity, because the optometry students then learn a little bit about what physio students do. So there were different ways we could timetable different activities. But also on those days when the discipline-specific supervisor wasn't there, we could have another person that was their go-to supervisor. So Rosie and I were able to check in with the students. We could run some interprofessional face-to-face tutorials with the students, and there were other ways that we could ensure that the students had great supervision despite it not being discipline-specific. Anything else you would add, Anthea?
I think just for anybody in the audience that might be a bit nervous about it, the innovation of these guys at the Go Rural Health team is amazing. So you can work things out which might feel impossible.
I think there's just a lot of value in looking beyond your own discipline. There are lots of opportunities and the students that report that they really value that as well. Perhaps we could ask everyone a question, Tara. I know you were keen to ask around what people here on the call might be interested in knowing more about in rural clinical education. Would anyone have anything that they'd like to add around something else they might like to learn about or know about in relation to rural health clinical education?
And you can pop it in the chat or just unmute. We've lost a couple of people, and so we're a fairly small group, so please just unmute if you'd like to.
Or even if anyone has any ideas around what opportunities they might see, just reflecting on what they've seen and heard tonight, if anything's popped into your mind about some opportunities of partnering or providing opportunities to students in rural health.
So we've got a question from Karen just about clarity about supporting students that you team place or sorry, I can't read the question very well. Karen, can you unmute and ask? I think it's got to do with university support when it might not be your local university.
Yeah, so I'm unclear if you support students that your team place or whether you can support students we have placed by a local uni. So Going Rural Health program can support students from any university that are on placement within our rural footprints. So that refers to the map of Victoria that we had earlier in the presentation. So yeah, if any student from any uni is undertaking a nationally recognised uni with an allied health course, it's quite a long list of allied health courses that are included. There is eligibility criteria for our program that's listed on our Going Rural Health website, so that might be a good place to have a look. Or if you have a student coming up and you're unsure whether they can link in with our program or not, maybe just drop us an email and we can let you know. Does that sound all right, Tara?
Yeah, I echo that, and a really good place to go is the website, and that will kind of provide most of that information. But yeah, any nursing or allied health student in our footprint, if they meet the eligibility criteria, will be able to access that support.
Yeah, they can tap into the bursary or student placement support scheme, into any of our education programs as well.
Yep. Well, it's now 7:14, so we will finish in a timely manner. But before we finish, I would just really like to thank Lauren and Tara for their presentation this evening, for their innovation, for the work they're doing that's so important for our rural communities, but just for our communities and professions in general. Really great for people to be with us tonight. Thank you for your time. Just letting people know that we are going to pause our events in June. So our next event in July, we'll be looking at a wellbeing topic, which is important for both staff and for students when we're in a placement setting. So if you do have the opportunity, please join us in July. And this is save the dates for Tuesday the 15th and Thursday the 17th of July. We usually send you around an email afterwards, so Lauren, you can advance to the next slide, but if you don't get the chance to grab the feedback QR code, then please just send an email, let us know what you would like to do and what you would like to hear more from in a Melbourne ACE sense. Other than that, I wish you all a very good evening, and we'll look forward to having you involved in a future event, we hope. Thank you.